I know I'm kind of preaching to the choir here. We're probably pretty familiar with definitions of integrated care, but just for some context setting, I really want to highlight sort of the difference between when we look at this from more of a system social science perspective versus from the patient perspective. So a definition that is used quite a bit is this first one about integrated care being a set of methods or models that focuses on funding, administration, service delivery, clinical levels, with really the goals to create connection, alignment, collaboration between more preventative aspects of care, so the cure piece, as well as the care aspects of care. So preventative and also the management of illness and social needs as well. And the goal is to really enhance the quality of life and quality of care that people receive, and also create efficiencies in the system by having people work together more in a more productive way. But most importantly, we're here today to really focus in on the patient, community, caregiver perspective, where this definition speaks from their perspective. I can plan my care with people who work together, who understand me and my care, allow me control, and bring together the services to achieve the outcomes that really matter to me. So I really, really like this definition because it really shines a spotlight on, we can be really fancy thinking about funding models and organizational factors, but at the end of the day, does it make sense to people who are using healthcare? And that's really where we're shining the spotlight. What do we mean by patient and caregiver engagement? So we talked about integrated care. Now, what do we mean about engagement? And it's really about people coming together, whether you're a patient, a family member, a friend, a neighbor, professional, an active partnership. And this could be in a clinical encounter. It could be at the organizational level where you're doing co-design work or planning something together, as well as the governance and policy-making level, and ultimately with the goal of improving health and healthcare. So pulling together our collective expertise to make things work better. And of course, there's also different degrees of engagement. And with these different degrees, there's different levels of power. So when we talk about engagement, we're talking about power. And clearly there's some groups that historically have a lot more power in these types of interactions than others. If we think of era one, and I'd like to think we're past era one, but not always, it depends on the context. And what we're focusing on, but is really about sharing information, how traditionally health systems have been set up to, I am the expert researcher, or I am the expert clinician, and I will share with you what I know, go forth and do as I say. That's a very kind of, very traditional. I'm exaggerating a little. I'm sure there's still more collaboration in era one, but really it's about one-way direction. When we move into era two, you start to see a little bit more sharing powers, the acknowledgement that we all have knowledge to bring to bear, and we start to have conversations about how we can build together, work together, but there's still not quite a shared equal power balance there. And era three, which is presumably where we would like to go, and it happens sometimes, but not always, is really where you see shared power amongst all people involved, where everyone feels valued. People can contribute to the level that they want to, and be involved and really shape the outcomes, really shape the process, and really feel like I matter, and my contribution matters, and I have a full understanding of what my contribution looks like. And so ideally, when we talk about engagement and co-design, that's what we're trying to do. And essentially, we do this to have collective impact. And what is collective impact? It's working together intentionally. It's about sharing information. It's about solving complex problems. And engagement is required for integrated care. And we can't do this alone. We can't work, as you can see in the second definition. It's not about being a single person or a single organization. We can't create massive shifts unless we work across the boundaries that we currently work in, and really think about creatively, how can we connect the dots for people so it makes sense for care teams and also makes sense for people who are using health and social care. And I'm going to leave with this quote that I really like from Catherine Milligan and colleagues, and I've used it in several presentations because it really shines a spotlight on what we're trying to do. And essentially, we're trying to harness really strong relationships amongst many different people. Relationships are the essence of collective impact, is how they start the quote. And we're trying to build empathy and compassion, authentic connections, between diverse participants, and these deep connections create innovation. It creates new ideas. It also takes time. Some people say, well, it's going to take too long to build these relationships and then do the work we need to do. But it's so critical that we really appreciate all the different types of knowledge each of us brings to bear. Single-handedly and as an individual person, we don't have all the answers. We have to really collectively look at that together. And this quote really kind of gets at sort of a similar sentiment, is that we need to really work together to move past these kind of like rational frameworks of just plug and play of creating change to a more authentic, consciousness altering way of working together and learning together so we can significantly change. So it's about kind of shifting the systems we work in and shifting our approaches and our methods of working as individuals.